Hello and welcome. I'm so glad you've joined me to learn more about erectile dysfunction. This important topic is a primer on erectile dysfunction to introduce you to erectile dysfunction, help you understand it better, and some of the treatment options available. My name is Dr. Jeffrey Albaugh. I am a board-certified advanced practice urology clinical nurse specialist. I'm also certified as a sexuality counselor and have been trained in couple therapy. I currently work at the Jesse Brown VA Medical Center here in Chicago. I previously worked at Endeavor North Shore Healthcare and Northwestern Memorial and have over 30 years of experience caring for men and women with sexual dysfunction. My PhD is in sexual health research, and I have written a book for men with prostate cancer, actually a first and second edition, called Reclaiming Sex and Intimacy After Prostate Cancer, in addition to being the editor on the core curriculum for Urologic Nursing, second edition adult version. This subject happens to be very near and dear to my heart because this is what I do every single day with patients. So I hope you find the information helpful, and I hope that it helps you to help your patients even better. So let's get started. I also do a podcast, so you can see there, www.drjeffsextalk.com, and you can hear a lot more if you want to hear more from me at that website. I like to start with anatomy and physiology, and I think it's so important. And this is a picture from the public domain that's out there. It's an excellent picture to help you understand this a little better. But what you're seeing here is the corpora cavernosa. You're seeing the paired cavernosa on top and then the spongiosum on the bottom. These are the cylinders within the penis that are full of smooth muscle surrounding blood vessels. The bottom one, the spongiosum, has the urethra running through it. All of these cylinders are full of smooth muscle that surrounds blood vessels. And that'll make more sense when I talk about how a normal erection occurs in just a minute. But remember this, you have these paired corpora cavernosa and this spongiosum. And here you can see the smooth muscle is kind of down around those blood vessels a little bit, but now you see the engorgement where we get 7 or 8 times more blood in these cylinders, which makes it hard. And we'll talk about what that does in just a minute. So we just said that the penis is composed of 3 erectile cylinders, the paired corpora and the spongiosum, and they're surrounded and enclosed by Buck's fascia. It's like a casing, just like, think of it like the casing on a sausage, and it covers the whole thing. The arterial supply, you can see there, it comes from the internal pudendal artery, which becomes the common penile artery, which divides into the cavernosal artery of the penis, the dorsal artery of the penis, and then finally the bulbal urethral artery. Now, how does an erection start? How does it happen? It starts with tactile sensation. That means sensation on the penis or psychogenic sensation or both. This is how it begins. That's put together in the central nervous system. Then that message goes down the spine through the autonomic nervous system to the peripheral nerves. When it hits the penis, it activates chemicals within the penis, neurotransmitters like nitric oxide and cyclic GMP from the cavernosal nerves, resulting in the smooth muscles relaxing, the blood vessels engorging or filling with 7 or 8 times more blood. This actually causes the sinusoids to trap. It pushes, they feel so full that they push up against Buck's fascia and close off those superficial veins and lock blood in the penis, and that's how a man gets an erection. So to put that together, you need nervous conduction back and forth between brain and penis and blood flow to engorge your penis to get an erection. Those are 2 essential components. So remember, any disease like diabetes that affects blood flow and nervous conduction will affect your ability to get and keep erections because you need good blood flow and you need good nervous conduction. Detemesis occurs, and so that erection also requires sympathetic inhibition and parasympathetic activation. And so when you get an erection, think parasympathetic is activated. Parasympathetic, the penis is activated, is how you'll remember that. Detumescence occurs with decreased parasympathetic, and increased sympathetic soft penis intervention. So think soft, sympathetic, and that leads to the smooth muscle coming back down around the blood vessels, the blood going back into the body, and detumescence occurs. So I hope that makes sense to you. It's a neurovascular event. It needs blood flow and nervous conduction, and that's really important. What about testosterone? Because patients are always asking about that. But testosterone is a hormone that works all over the body, and it has a small role with erections, but it has a big role with libido or sex drive. So it is important, but the key essential components is blood flow and nervous conduction. What is erectile dysfunction? Well, it's defined as the consistent recurrent inability to get and keep an erection or rigidity sufficient for the sexual performance, satisfaction, or experience. That is what erectile dysfunction. They can't get and keep an erection sufficient for the sex they're trying to have. Is it common? Well, 1 in 5 men in their lifetime will have erectile dysfunction. It's very common. And remember, as you get older, it becomes more common. Younger men, it's not so common. About 5 to 20% when we think about younger men will have it, especially in their 20s, about 5% or so. But when we put together 20s to about 39, about 10 to 20% when you look at the literature, and it varies. 40 to 59, about 30 to 50%, varies again. 60 to 79, now we have 60 to 80% of men. And by 80, most of the men, certainly in these older age groups, will have it, 70 to 90%. They say by the time you're 80, about 80% of men have erectile dysfunction, difficulty getting and keeping erections. And yes, it has some to do with aging, because aging seems to adversely affect many things, most things. As you get older, you need a sense of humor because things start changing, and oftentimes not for the good. But you do get wiser, which is a good thing. But the comorbidities are even more important than the aging process on what affects erections, right? Because if it affects nervous conduction or blood flow, it affects erections. Diabetes affects both. High blood pressure affects blood flow. Hyperlipidemia affects blood flow. Heart disease affects blood flow. The blood vessels of the coronary arteries are about 4 or 5 times bigger than the blood vessels in the penis. So you can imagine which one's going to get clogged first. So erectile dysfunction can be a harbinger or a very first sign of cardiovascular disease. Even lower urinary tract symptoms and BPH has been associated with erectile dysfunction, and certainly things like depression, anxiety, PTSD. So many things can affect erections, that's for sure. How do we evaluate it? Well, we want to do a thorough medical, sexual, and psychosocial history. That's going to be really important because we got to get to the bottom of, do they have medical issues? Are they on medicines that impact erections? Is it a relational thing? Pulling it all apart. And that can also be pulling apart that sexual history. When do they have problems? Is it with a partner? Do they have problems? And I always ask, when you self-stimulate, are there any problems with erections then? Do you wake up with erections? Because men get erections every day of their life. Remember, the penis goes up and down while you sleep, usually several times a night, and the penis is erect sometimes about 2 out of every 24 hours on and off during deep sleep. So deep sleep is critical to testosterone production, and it's critical to erectile function because the penis literally works out while you sleep to keep itself in shape. So cool. If our bodies did that, we'd all be in amazing shape, right? But the penis does do that when it's working properly. From the day you're born till it stops working right, if you have a penis, it goes up and down while you sleep to cause muscle activity and blood flow, and literally works the penis out during sleep. So you got to do a thorough history. You want to use a validated questionnaire like the International Index of Erectile Function, whether you just use the part for erections, which is a 5-point questionnaire, or the full questionnaire, which also looks at orgasm and other things. So you want to use a good validated questionnaire, and that's the main one I use for erectile dysfunction, the IIEF, the 5 or the full one, either one. You want to counsel that erectile dysfunction is a risk marker for underlying cardiovascular disease. It precedes cardiovascular events by about 3 to 5 years. So this is really important to help patients know. When you start having when you start having pretty continuous erectile dysfunction that's not responding very well to pills or whatever, there is a chance you will have a cardiovascular event in the next 3 to 5 years, so you wanna get really healthy. And it also can be a sign of other underlying health conditions like diabetes or high cholesterol, many, many different things. In men with erectile dysfunction, if you wanna check testosterone, although it has a small role with erections, we still like to check it to make sure it's okay because if they really have a deficiency in testosterone, that if the deficiency is great enough, it may affect erections as well as libido, the main thing that it affects, but it can affect memory, concentration, uh, building muscle versus fat gain. It can affect mood, it can affect energy levels, so many different things because it works all over the body. But a morning serum testosterone, preferably fasting, should be measured just to double check that everything's okay there as well. Only about 5% or less of erectile dysfunction is caused by hormone imbalances like a testosterone deficiency. Surprisingly, but it's true because it has a smaller role with erections, remember. Most erectile dysfunction is caused by vascular issues. So vascular is the most common cause because many men have high blood pressure, cholesterol issues, heart disease, and blood flow problems, or even obesity, which impedes blood flow, diabetes, lots of different things. So blood flow is the number one, but it could be a blood flow issue, it could be a neurologic issue, it could be hormonal. You really want to evaluate all of that. For some men with ED, specialized testing can be done, but it doesn't have to be done. When a man tells you and they know if their penis is working right or not, are you getting night erections? Are you getting erections with self-stimulation? Are you struggling with a partner? Do you have trouble maintaining, keeping one, or do you have trouble even getting one in the first place? Or both. Those are all the things that you're evaluating and pulling apart. It's like putting a puzzle together. It's kind of cool. So you figure out exactly what's going on and what you can do to help. So we already talked about many things affect erectile dysfunction, but chronic medical issues, certainly cancer treatments, especially down in the pelvic area, prostate cancer treatments or treatments down in that area, radiation and surgery, different things like that could affect. Chemotherapy can affect as well. But cardiovascular disease, neurologic disease, metabolic disorders, endocrine disorders, so many different things can affect sex and intimacy. We talked a little bit about PTSD, depression, anxiety, but also bipolar, schizophrenia. Many of these things and the medicines that they're on also can and often do impact sexual function. The most common impact of, for example, the very popular SSRIs for depression and anxiety is prolonging time to climax. And some people even have trouble reaching their climax when they're on some of those medications. I talked a little bit about pelvic and perineal trauma or surgery and how that could impact the peripheral nerves down there for erections. Spinal cord injury, that should make sense now, or head trauma, anything of the neurologic system. We talked about radiotherapy, especially for prostate cancer, which can be brachytherapy, external beam, or proton beam. Medications, a lot of people are on antihypertensives, and some of the main excellent antihypertensives may impact erectile function. So you have to look at those carefully to see and work with the prescriber to see if something can be done about those medications in particular. I don't change those medicines. I just work with their prescriber to make some recommendations on things they might try if we think the primary reason for the problem is their, for example, their beta blocker antihypertensive or their diuretic. But we certainly don't want, because if they have out of control blood pressure, they're going to have erectile dysfunction. About almost 3 out of 4 men with high blood pressure have erectile dysfunction. So we want to control the blood pressure, but we can do some tweaks to medications with the prescriber doing those tweaks and our recommendations. Smoking is an erection killer. Alcohol in large amounts can cause problems, and recreational drugs. And then even just a sedentary lifestyle. Our bodies were designed for movement, and it's really important because it promotes blood flow and erectile health. If it's good for your heart, it's good for your erections. So I just wanted to say a little bit about how, and this is from even this research that is most recent here, you can see multiple studies, but even 2024, erectile dysfunction is an indicator, as I said earlier, of underlying cardiovascular disease, unless we know the patient has a spine injury and we know that's why they have erectile dysfunction. They had prostate surgery and we know that's why they have it. But if we're not absolutely sure of the reason, we certainly are looking for underlying cardiovascular issues, and we're trying to get them healthy to avoid a cardiovascular event, which can occur in 3 to 5 years, according to the research, after erectile dysfunction is consistent. So you could, but so many things, obesity, type 2 diabetes, I put a list there, depression, high blood pressure. We've talked about a lot of things. If it affects blood flow or nervous conduction, it can affect erections, and that's what you should be looking for. When the patient is in their top form, they have the best cardiovascular health. Now we have the best chance of the best sexual health. So, what are the consensus recommendations? And those recommendations, according to the research, is for men with ED, and this is a new consensus statement that came out in 2024. The other one was over a decade old, and so they had a new consensus recommendations from Princeton consensus, and that's very exciting. But they're saying that, continuing to say that men with ED and no known heart disease, the guidelines suggest that we should be screening them for cardiovascular risk factors and doing a coronary artery calcium scoring test, which is a non-invasive, affordable test that can be done. We use exercise capacity. Do they tolerate going up and down 2 sets of stairs, to categorize them as low if they tolerate it perfectly with no chest pain or shortness of breath? That would be a low risk category, intermediate, or high. And it is based on how they tolerate exercise, according to the Princeton consensus. But remember, this pulls together all the information that reminds us that there's a great link between erectile dysfunction and cardiovascular disease. So, how do we treat erectile dysfunction? Well, first off, it's patient and partner centered. It's about no one else but the patient and their partner. No one else's opinions matter. Mine, no one else's. So, what we try to do is present them with the evidence based scientific information on each treatment, because every treatment has good and bad, and that gives them the information they need to make their own informed decision. I like them to come in together with their partner. If they have a regular partner or partners, they need to come in together so that they can make these decisions and understand things together if they're comfortable with that. We want to address and treat any underlying causes, and we don't do that ourselves. We work with primary care, with endocrine, with cardiology to help them treat those underlying causes we talked about earlier. Lifestyle changes. I cannot emphasize how important the triad of diet, exercise, and weight control are. Dr. Mark Moyad at the University of Michigan has a paid endowed chair as a urologist to look at treatments that help besides medicinal treatments and surgeries, in terms of complementary therapies to help people with urologic issues, including sexual dysfunction. And he says there is nothing like diet, exercise, and weight control. Nothing is shown in the evidence to do what that triad of three things will do for overall cardiovascular health, so you don't have a heart attack or stroke, and for erectile function to improve that. Of course, smoking cessation, minimal to no alcohol or recreational drugs, and sleep hygiene is incredibly important, because while you sleep, you build testosterone and you have erectile activity when everything's working normally. But we also have pharmacological agents. We have pills, we have shots, we have a vacuum device as well, and we have surgery. And so, in terms of lifestyle management, the Princeton 4 guidelines strongly recommend that lifestyle changes are used as a very first line of treatment. I can't stress that enough. I think I have stressed it a lot, so you know. We do a lot of work around diet, exercise, weight control, and smoking cessation, and decreasing alcohol and things like that in my clinics. Every single day we do that with men and women both, but certainly with our men with erectile dysfunction. Comorbid conditions must be controlled. We've talked about that. And then hopefully this is going to improve health and quality of life. So we have oral agents, pills, sildenafil, vardenafil. Sildenafil is also called the trade name Viagra. Vardenafil used to be called Levitra, but Levitra is no longer available, only Vardenafil, but it is available, and these are all available in generic forms. Tadalafil is also available in daily doses as well as on-demand doses. And finally, Avanafil, which gets in and out quicker. It gets in about twice as fast. With the first three, they take about 30 to 60 minutes to get in, and they peak in about an hour to 2 hours typically. So anywhere between 30 minutes and 2 hours, depending on the patient, they'll get a peak effect from the medication. Most people between an hour and two. You can see the dosing there. They basically block phosphodiesterase type 5 so that we have more cyclic GMP and the neurotransmitters that help cause smooth muscle relaxation and vasodilatation, which leads to penile engorgement and erections. So they work inadvertently and tangentially by blocking. So it's like math. We have a double negative. If we inhibit the inhibitor of the chemicals in your penis that make you hard, now we inhibited the inhibitor. It's like a double negative. So we have more chemicals in your penis so that when you get excited, you get harder. And so there's lots to know about oral agents, but the timing is probably the most challenging thing. But men are very open to trying these. But the thing about it is they don't work for everybody. They work in about 70% of patients. And if erectile dysfunction continues to progress, which it will if you don't turn it around through lifestyle things and getting really healthy and controlling medical issues, it will progress beyond what the pills can do. But the pills are the number one most popular thing by a landslide. Everything is good and bad, though. So timing is what people complain about. Some side effects, different things. So things to think about with them on lots of things. The main side effects are headache, nasal stuffiness, facial flushing, stomach upset for all of them. Muscle aches with tadalafil, blue halos with sildenafil. So different things to think about and work with the patient on and helping them with that timing of when will you take it? Do you have to take it on an empty stomach like sildenafil? Things like that. The vacuum device is completely non-invasive and it works. It's physics. It forces more blood in the penis. So you take that semi-flaccid or flaccid penis or semi-erect penis and you put it in the cylinder that you see here. And when you put it in, these are two examples of different ones. There's lots of different excellent medical grade devices out there. When they put these are two that are in the public domain pictures of Post-Evac and Erecaid. They're just two of many really excellent devices. But they put their penis inside the cylinder, and when the penis is in the cylinder, you start to pump the pump, which creates the suction and forces more blood in and makes the penis harder inside of there. So it gets harder from that positive pressure pulling blood in there. And once it's hard enough, you transfer a ring off the base of the device to the base of the penis, and that's how it holds the erection. The best thing is it's non-invasive and it works in about 90% of patients. It's physics, but it's messy. It's cumbersome. You have to wear a ring during sex. Everything is good and bad. So does the vacuum pump. Eroxon is a new over-the-counter topical gel. It causes a cooling on the skin level that brings more blood in and increases blood flow that way. This was a study, the studies that the FDA had them do with 250 men, and they had erectile dysfunction greater than 3 months. 60% of them had erections within 10 minutes, and 60% of them had minimally clinically important differences in their International Index of Erectile Function scores. So again, 60% of them had improvement in their erection hardness. So does that mean they could get through sex and do okay? It remains to be seen with the patient and how well it helps them. But you can think to yourself, it probably doesn't work as well as pills or some of the other things that have better efficacy, but it's non-invasive and it may work for some patients. It is over the counter and you do not need a prescription for it. Then there's injections where you inject yourself in the penis each time you want to have sex. There's several different versions of it. Trimix is a combination of three drugs. It's papaverine, phentolamine, and prostaglandin E1, which is also called alprostadil. One of those drugs, alprostadil, prostaglandin E1, was taken and FDA approved, and so you can see that Edex and Caverject are the FDA approved versions of that alprostadil or prostaglandin E1. That is the one drug of the three that causes an achy, like a headachy, throbby pain in the penis in a third of patients. So some patients will get pain as the drug kicks in, and so that is something to think about. Trimix is non-FDA approved, off-label, but it's been used and investigated since the 1980s, but it is off-label, non-FDA approved, so it is not typically covered by, of course, any insurances or anything like that, but it is much cheaper. But all of them are designed to cause smooth muscle relaxation and vasodilatation. They have good and bad, positives and negatives, and things for the patient to consider. They can cost money because things are not often covered by insurance. And so there's a lot of things to consider. Is this right for the patient or not? They have to learn to self-inject themselves each time. And again, there can be some side effects. The most common one being pain, an achy pain that kicks in, especially from the alprostadil or prostaglandin E1. But the other ones can be bleeding. You put a needle in the penis in a vascular area. Bleeding is the second most common. But you can get permanent scarring or priapism, an erection that won't go away that's a medical emergency. Those are not common, but they can occur in up to 10 to 15%. So a lot of things to teach and work with the patient. It's always done in clinic under supervision. So you make sure they know how to do it and do it appropriately, effectively, and without problems. And so they do the first dose in the clinic. They learn how to do it. They study it. They come in and do it. And then they go from there. So that's penile injections, good and bad with every treatment. Then there is the surgery and the penile implant surgery. Only about 1 to 3% of patients with erectile dysfunction will go on to do something like a penile implant, but the patients who do, 80 to 90% of those patients are pretty happy with that. But many patients don't want to do an elective surgery. And so, again, not for everybody. I'm just glad we have the different treatment options, this being the most invasive and permanent. Once you put this in your body, even if you take it out, just like a knee or hip replacement, you will not be the same, and you need to assume those patients who do it that they won't be able to go back to other treatments like the vacuum device or pills or the shot because they won't work as well after all this is put in there and structurally things have changed within the penis. Like if you had a knee replacement and you took it out, or a hip replacement. When you put all these things in and take them out, it's a permanent kind of thing. So that's important for patients to know. But having said all that, patients and partner satisfaction is very high if and when they decide to do this treatment. And it is a viable treatment as well with good and bad. More risks as you get more invasive. So as we become more invasive with shots, with penile implant surgery, more things to consider and less people will do these treatments because they're more invasive and they have more things and risks to think about. Here's a couple resources. Again, my website has all kinds of information on it about sex, intimacy, and relationships. The video library that I created initially at North Shore is on that website. It's called Endeavor North Shore Healthcare now. Patients with prostate cancer can get a free copy of my book. They can download it for free, or they can buy one, but they can download it completely free thanks to some very generous patients of mine from the past at drjeffalbaugh.com. Cancer, if they have prostate cancer, there's some excellent resources from cancer.org or cancer.gov. And then last, the Sexual Medicine Society Sexual Health Matters has a wonderful website with valid, good resources for people as well, for your patients. I hope this helps. I know it was a lot. I hope I didn't overwhelm you, but we did a whirlwind overview and primer on erectile dysfunction. And mostly, I just hope it gives you what you need to help your patients to heal and have better sexual health and more deepened, meaningful relationships with their partners. Thank you.